Hello viewers, I am Dr. Robiul. I work as a lecturer in pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is on alcoholic liver disease part 2. In the previous video of this series, we had defined alcoholic liver disease, talked about the metabolism of alcohol, and we had also discussed the morphology of the 3 forms of liver injury that we see in alcoholic liver disease. In this video, we will finish our discussion by talking about the pathogenesis, clinical features, diagnosis and treatment of alcoholic liver disease. Okay, so a lot of topics, so let's begin. And we will begin our discussion by talking about the pathogenesis of alcoholic liver disease. So, as you can see, in order to explain the pathogenesis of alcoholic liver disease, I have drawn a flowchart in the whiteboard. And in your textbook, you will see that there are about 10 mechanisms involved in the pathogenesis. So now we will discuss those 10 mechanisms. So one of the mechanisms is by the direct hepatotoxic effect of ethanol. Now always remember, ethanol can directly damage the liver cells. Ethanol is toxic for the microtubules, mitochondria, and the membranes of the hepatocyte. So that is one mechanism. However, at the same time, you have to remember that the major hepatotoxic effect of alcohol is exerted not by ethanol but by its metabolites, and mainly by acetaldehyde. Recall from my previous video where we had talked about ethanol metabolism, we had seen that ethanol first is metabolized into acetaldehyde, and later acetaldehyde is metabolized into acetic acid. And this acetaldehyde is important for exerting the hepatotoxicity that we see in alcoholic liver disease. So this is one of the major culprits that can cause liver damage. So how does acetaldehyde hamper or impair liver function? The thing is, acetaldehyde will produce 2 types of adducts. One is called the protein aldehyde adduct, and the other type of adduct, which I had written here as MAA adduct, this is in fact malone dialdehyde acetaldehyde adduct. And both of these 2 types of adducts are hepatotoxic. For example, the protein aldehyde adduct, it can damage the cytoskeleton and the membrane of the liver cells, and ultimately there will be necrosis of the liver cell. On the other hand, the second type of adduct, that is the malone dialdehyde acetaldehyde adduct, this thing can produce autoantibodies, and that will result in autoimmune injury to the liver cells. Moving on to this part of this diagram, we can see that the third mechanism is by inflammation. Always remember, chronic alcohol consumption not only damages the liver cells but also damages the cells of our intestine. That will result in alteration of the permeability of endotoxin from the gut inside the blood. So more and more endotoxin will now enter the blood. There will be a condition known as endotoxinemia, and also there will be inflammation. So there will be liberation of tumor necrosis factor alpha, interleukin 1, interleukin 6, transforming growth factor beta, etc. And all these things will result in inflammation, and they will damage the liver. So that was the third mechanism by which alcoholic liver disease can happen. The fourth mechanism that we will talk about is fibrogenesis, and this will happen due to activation of the hepatic stellate cells. And in your textbook you will see that hepatic stellate cells can be activated by various stimuli, for example damaged hepatocyte, Malon dialdehyde acetaldehyde adduct, activated Kupffer cell, and the direct toxic effect of acetaldehyde. All these things can activate the hepatic stellate cell or ETO cell, and then that cell becomes transformed into myofibroblasts and fibrocytes, and they will produce fibrous tissue, for example collagen, and that will result in fibrogenesis. Moving on to the fifth mechanism that is involved in the pathogenesis of alcoholic liver disease, and that one is oxidative stress. Recall from the previous video where we had talked about alcohol metabolism, we had seen that alcohol is also metabolized partially in the microsome. For example, we had mentioned the microsomal ethanol oxidizing system, where we had seen cytochrome P450. And during those metabolism, we also had seen that there was generation of free radicals and reactive oxygen species, and those things will damage the membrane and also the proteins inside the liver cell, and that will also result in liver injury. So these were the 5 major mechanisms involved in the pathogenesis, but recall we had said that there were 10 mechanisms described in your textbook. So where are the other 5? You can see I have written them here. So let's talk briefly about the other mechanisms. Alcoholic liver disease can also happen because of impaired cell-mediated immunity. The thing is, alcohol can directly impair the cell-mediated immunity, and that can also result in liver injury. Similarly, alcohol will increase the redox ratio. We had talked about this in the previous lecture, where we had seen that during alcohol metabolism, the amount of reduced nicotinamide adenine dinucleotide, which I had written as NADH, that thing was getting increased, and that will alter the redox ratio. The redox ratio will now get increased, and that will have some biochemical alteration, and ultimately that will also result in liver injury. Another mechanism was retention of protein and water. The thing is, chronic alcohol consumption can prevent or can impair the secretion of various proteins from the hepatocyte. So proteins will not get liberated or released from the liver cells. They will begin to accumulate inside the liver. Water will also begin to accumulate, and that thing will result in swelling of the liver cells and also liver injury. So that is another mechanism happening due to retention of protein and water inside the hepatocytes. Another mechanism was by hypoxia. The thing is, alcohol can increase oxygen demand, and that will result in hypoxia in the liver, and ultimately that will result in liver injury. Another mechanism involved in the pathogenesis of alcoholic liver disease is by increasing the amount of fat in the liver. Now, how is this thing happening? The thing is, alcohol results in shunting of the normal substrates away from the catabolic pathway towards lipid biosynthesis. So that's one mechanism of increasing fat inside the liver. At the same time, alcohol can result in impaired release and impaired assembly of lipoproteins. So since lipoproteins are used to transport lipid from the liver, if there is impaired assembly and impaired release of lipoprotein from the liver cell, fat will begin to accumulate inside the liver cells. So that is another mechanism. And the third mechanism is by increasing the catabolism of fat in the peripheral tissues. So all these things will result in increased amount of fat in the liver, and that will also result in liver injury. So now that we have talked about the 10 mechanisms involved in the pathogenesis of alcoholic liver disease, now we will move on and talk about the clinical features of alcoholic liver disease. Now, recall from our previous video, we had said that alcoholic liver disease is a term that denotes spectrum of liver injury. So the clinical features of alcoholic liver disease are also very variable. It can range from very mild symptoms to all the way to very severe symptoms. In hepatic steatosis or fatty liver, there can be enlargement of the liver, that is called hepatomegaly. In alcoholic hepatitis, there can be hepatomegaly and jaundice, and the patients of alcoholic hepatitis may develop this disease in a very acute nature. Their history may contain history of heavy drinking, and in many cases there can be cirrhosis superimposed with alcoholic hepatitis as well. And one thing you have to remember, the prognosis of hepatic steatosis is good. If the patient stops drinking, then the hepatic steatosis can be reversed back to normal within 3 months. The prognosis is worse for alcoholic hepatitis, and the jaundice that we had just mentioned in alcoholic hepatitis, it takes at least 6 months of abstinence from alcohol to make the jaundice subside. Moving on to the clinical features of alcoholic cirrhosis, there can be clinical features due to the complications of cirrhosis. For example, there can be variceal hemorrhage and ascites. And one thing you have to remember, in alcoholic cirrhosis, the palmar erythema is more common than that happening in other non-alcoholic causes of cirrhosis. So this thing is very important for your multiple choice question. Always remember that palmar erythema is more common in alcoholic cirrhosis compared to liver cirrhosis happening from other causes. So these were in short about the major clinical features, and in your textbook you will see also some non-specific clinical features that can be also seen in alcoholic liver disease. The non-specific clinical features will include anorexia or loss of appetite, weight loss, malaise, upper abdominal discomfort, tender hepatomegaly, etc. And what do we mean by tender hepatomegaly? Here the patient's liver will be enlarged and also tender in nature. So now that we have talked about the clinical features of alcoholic liver disease, now we will move on and talk about the diagnosis of alcoholic liver disease. Now, the diagnosis of alcoholic liver disease is based on history of alcohol abuse, clinical features, and of course on the laboratory findings. Now, regarding the history of alcohol abuse, in many cases the patient may minimize or even deny the history of alcohol abuse. So the challenge is to gain the trust of the patient so that the proper amount of alcohol consumed can be known. We have already talked about the clinical features, and we had seen that they are variable in nature. Moving on to the laboratory findings, the liver function tests are very important. Almost all the liver enzymes will be elevated, and particularly the amount of aspartate aminotransferase, which I can write as AST, and the amount of alanine aminotransferase, which is written as ALT, they will be elevated. However, they are usually less than 300 international unit per milliliter. And also very important for your exam is the ratio between these two liver enzymes. And the ratio of AST and ALT will be greater than 2 in case of alcoholic liver disease. In other words, whenever the ratio between aspartate aminotransferase and alanine aminotransferase is more than 2, it is highly possible that the patient is suffering from alcoholic liver disease. So always remember this ratio for your exam. In chronic alcoholics, the amount of uric acid in the blood will be also elevated, and that will result in hyperuricemia and gout. And we had mentioned the mechanism of hyperuricemia in the previous lecture. Recall that we had said that uric acid and lactic acid use the same transport system in the kidney, and that lies in the mechanism of hyperuricemia. Since more and more lactic acid is using that transport system, so uric acid begins to accumulate in the blood. And in chronic alcoholics, there can be also elevated level of triglyceride in the blood, and that will lead to hypertriglyceridemia. Now, one important finding that we can see in chronic alcoholics is regarding one of the red cell index, and that is the MCV, or mean corpuscular volume. Okay, so the mean corpuscular volume of the red blood cells will be increased, and as a result the red blood cells will be larger in size. That will be called macrocytosis. However, usually no anemia will be seen here. So whenever you hear the buzzword macrocytosis in the absence of anemia, that can indicate alcohol abuse and alcoholic liver disease. And in many cases, in order to know the extent of liver injury, liver biopsy may also be indicated. So these were in short regarding the diagnostic methods that we need to diagnose alcoholic liver disease. And now we will move on and talk about the treatment of alcoholic liver disease. Now, since alcoholic liver disease is occurring due to excessive consumption of alcohol, so the first treatment of alcoholic liver disease is obvious, that is, cessation of alcohol intake. Abstinence from alcohol consumption will not only improve the health condition of the patient, but it will also prolong the life expectancy in the long run. So as you can see in the whiteboard, during the management of alcoholic liver disease, the first thing we have written is to provide information to the patient about the harmful effects of excessive alcohol consumption and to make the patient stop drinking. Now, in order to do that, some lifestyle modifications may also be required. So you can see the second point is alteration in the leisure activities of the patient. Now, often patients are consuming excessive alcohol due to some psychological causes, and those psychological causes should also be dealt with, and that's why we have written the third thing, that is psychological treatment, and counseling should also be provided. Now, suppose you have informed a patient of alcoholic liver disease about the harmful effects of excessive alcohol consumption, and you have also made some lifestyle modification in the patient's leisure activities, and now the patient is willing to stop drinking. But whenever a chronic alcoholic patient stops drinking, there can be development of alcohol withdrawal syndrome. So first, let's talk about alcohol withdrawal syndrome. So it will contain some symptom complex, so we will now talk about those things. So there will be some psychological symptoms here when a chronic alcoholic person is stopping his drinking habit. For example, the person may experience restlessness, anxiety, and even panic attacks. There will be also some autonomic symptoms when a chronic alcoholic person stops drinking. For example, the heart rate may be elevated, there will be tachycardia, excessive sweating, nausea, vomiting, dilatation of the pupil. All those autonomic features can be seen during the alcohol withdrawal syndromes. And in your textbook, you will also see a term that is called delirium tremens. This can be also seen in a chronic alcoholic person when the person stops drinking. And the thing is, there will be delirium, the patient will be highly agitated, and there may be even hallucination in that patient as well. And in your textbook, you will see that there will be auditory hallucination too. And the patient may also experience delusion, illusion, even seizure. So all these things can happen during the alcohol withdrawal syndrome, and those things has to be dealt with. And the drug of choice here is benzodiazepines. For example, diazepam can be given, the dose is 20 milligram 4 times daily initially, and then the dose should be tailed off over a period of 5 to 7 days when the symptoms are getting subsided. So moving on to the next treatment, and you can see a term here that is Wernicke-Korsakoff Syndrome. This thing can happen in chronic alcoholic person, and this is a very important disease to discuss. So let's now talk about this thing. So what is Wernicke or Wernicke-Korsakoff Syndrome? This is a disorder. This is an organic brain disorder. It can happen due to deficiency of vitamin B1 or thiamine. And whenever there is vitamin B1 deficiency or thiamine deficiency, that can damage some areas of our nervous system. They will include the mammillary bodies, dorsomedial nuclei of the thalamus, and also some adjacent areas. So what will happen next? When those areas are damaged, initially there can be Wernicke's encephalopathy, and what will happen during that stage? There will be some clinical features like nystagmus, that is the involuntary rapid movement of the eye. There can be also ophthalmoplegia, that is the paralysis of the ocular muscles can also happen, and there can be also ataxia during this stage. And if this stage is not corrected by providing vitamin B1, it can also progress to the next stage, and that is the Korsakoff psychosis stage. So what will happen during that stage? During Korsakoff psychosis, there will be short-term memory deficit and also confabulation. Now, this is a very interesting term. What do we mean by confabulation? Here, the patient will produce fabricated, distorted, or misinterpreted memories without any conscious intention. That means during the Korsakoff psychosis stage, the patient is suffering from short-term memory loss, and there are a lot of gaps in the patient's memory, and then without his conscious intention or her conscious intention, the patient will produce some fabricated or false memories or misinterpreted memories, and he or she will be very confident that those memories are real, although in reality they are not real memories, they are fabricated memories. So that is confabulation. So one additional thing you have to remember, that although we are saying Wernicke-Korsakoff Syndrome in one sentence, but as a matter of fact they are two separate entities, and it is not necessary that first there should be Wernicke's encephalopathy and that should be followed by Korsakoff syndrome. They can happen independently as well. Although in most of the cases initially we see Wernicke's encephalopathy and that is followed by Korsakoff psychosis. And what will be the treatment? So we cannot prevent the stage of Korsakoff psychosis, so our target should be to prevent the previous or the Wernicke's encephalopathy stage if possible. And in order to do that, high dose of vitamin B1 or thiamine is needed. It is given in parenteral or intravenous route. You can see that we have mentioned the name, that is Fibrogenesis, and the dose is 2 vials 3 times daily for 48 hours, and that is followed by the oral drug, and the dose will be 100 milligrams 3 times daily. This will prevent the Wernicke-Korsakoff syndrome. Moving on to the next treatment, we have to reduce the craving of alcohol, and the drug of choice here you can see is Acamprosate, and the dose is 666 milligram 3 times daily. And the next drug is very important. The examiners are very fond of asking this question, and that drug is Disulfiram. And why should we give this drug? Disulfiram drug is given to the patients who are having difficulty in stopping their alcohol consumption habit. The thing is, disulfiram blocks the metabolism of alcohol, and that results in accumulation of acetaldehyde. So whenever a person who has taken disulfiram drug consumes alcohol, that will result in excess accumulation of acetaldehyde, and that will cause some unpleasant sensation in that individual. The individual will have nausea, headache and flushing. So whenever a person who has taken disulfiram drug consumes alcohol, he or she will feel bad. And that's the mechanism by which disulfiram drug is used to make a person stop drinking. And the examiners are very fond of asking the mechanism of disulfiram, so always remember this for your examinations. And the dose is 200 to 400 milligram disulfiram daily. Now, since in many cases the patients are consuming excessive alcohol due to some psychological causes and often due to depression, so antidepressant medications may also be required, and also sometimes antipsychotic drugs are also needed. For example, in some cases alcoholic patients can develop hallucination, and to counter those hallucination, antipsychotic drugs, for example chlorpromazine 100 milligrams 3 times daily may be needed. The next treatment is to provide sufficient nutrition to the patient. This is very important. Alcoholic persons are often malnourished, and we have seen that they have deficiency of vitamin B1, so all those things should be taken care of. The next drug of choice is corticosteroids, and they are given particularly in severe cases, but always remember these drugs have side effects and they can result in sepsis, so steroids are contraindicated if the patient had pre-existing sepsis or if the patient had variceal hemorrhage. In those cases we should not give steroid. Another drug is pentoxifylline. This is a very weak anti-tumor necrosis factor drug, and this can be also used for treatment. The last treatment of choice that I will talk about is liver transplantation. However, this is a very controversial topic, and if the patient develops alcoholic hepatitis, liver transplantation has a very poor prognosis, and therefore it is seldom done in a patient with alcoholic hepatitis. However, for cirrhosis, liver transplantation may be needed in some cases. So this concludes today's video on alcoholic liver disease part 2. I hope this video was helpful. If you like my videos, do comment, share, and let me know. And for my students, I will also recommend you to go through your textbooks to know more informations. Okay? So that's all for today. Until next time, take care and stay blessed. Thank you.